Hi, good afternoon, everyone. Thanks for joining us for advanced echo teaching in the critical care. I'm going to sort of split this session into sort of two parts. One is this echo and ARDS talk that I've been preparing, which I think might be good for the exam to sort of talk about a systematic approach to vivas. And I'll fire off just a few questions with every echo image I bring up. And the next one is an actual sort of viva that I've prepared, which is absolutely in the frame of what the DDU exam will be, which is in a couple of weeks. Please interrupt me at any moment. Otherwise, we'll just sort of crack on, and I'm going to fire questions, particularly those of you doing the exam, but also those of you just starting, okay? So with ARDS, or with the approach to sort of echo and ARDS, and I think this goes for a lot of these kind of broad questions that we're going to ask in the exam, is that it's important, if you're thinking broad, to have a systematic framework to it. So for example, if we're asking you a question on how to use echo in respiratory failure, or how to use echo in ARDS, or if there's a specific tilt, for example, there was a tilt in the exam about someone with respiratory failure, intubated with LFT derangement, a lactic acidosis, and acute kidney injury, as in you've got someone with respiratory failure with potentially either a congestion issue from RV failure or a forward flow issue from LV failure. This is the kind of framework that you've got to try and get through pretty quickly for those written questions. And I know not all of you are doing the written exam, so forgive me if I'm going over old stuff for those. But so if you're talking about echo and respiratory failure, this is my kind of thoughts about what we've got to look at. We've got to have this idea that we've got to start off with talking about systolic function of the LV, then left atrial pressure, and that buildup that's going to be felt back in the lungs. Then from the lungs back to the RV systolic function. Don't forget about shunts. And then maybe we'll try and have a crack at doing volume status. There's quite a lot to get through. And I guess what your job is to try and figure out how to talk about all of this in very broad brushstrokes in the allotted time, which is 15 minutes. And I always encourage you to try and write to 13 to give yourself some times off afterwards. All right. So if we're talking about the left ventricle, so let's start off by talking about the left ventricle systolic function. So what I'm trying to impart by showing this slide is for any assessment of LV systolic function, you've got to have an assessment across all views possible. So we've got parasternal long, parasternal short, and the apical four-chamber, and of course you can add in the subcostal under that. So let's start nice and simple. Lewis McLean, give me the walls of the heart that you can see in the parasternal long.
Okay, so that's the anteroseptal and the infralateral wall.
Beautiful.
Systolic function. No, you didn't ask me that.
That's excellent. All right, Vishal, what are so if you've got the short axis view here, what are the two papillary muscles called and what's their blood supply?
So anterolateral and posterior medial. Anterolateral there's a dual supply, LAD or circumflex.
Beautiful.
And whereas the posterior medial, there's like only one blood supply, either RCA or circumflex.
Very nice. Sid, what are the walls of your apical four-chamber?
Infroseptal on the left and the anterolateral on the right.
Very nice. Ben, while I just say you're not feeling left out, give me, so we can see the right ventricle here in the apical four-chamber view. Can you tell me all measures of RV systolic function that you can get from your apical four-chamber view? And you can use Doppler or whatever, but give me all measures of RV systolic function assessment in the apical four-chamber view.
Yeah, certainly. So just from the B mode imaging, I can get fractional area change.
Yeah.
I can get just hard systolic and diastolic measurements. I can get TAPSI, I can get an S prime. If I've got good enough image quality, I can get some strain imaging off the RV free wall as well.
Very nice. And just give me the measures if you have normal to abnormal for each of those, fractional area change.
Or greater than 35% is normal.
Nice. TAPSI?
TAPSI greater than 18 is normal. Or 18 or greater.
16, I think there is, I think the American Echo Board has a little bit higher, but I got 16, I think is the classic one, 16 millimeters. S prime?
So 9.5 is the cut point.
And I'm a bit low, I've got 8, but I guess it depends on the measure you're looking at. And RV free wall strain?
Ooh, 18%?
Yeah, a bit higher. It's about minus 25% for some things or minus 21 for others.
Okay, right. Yeah, no, that was yeah.
For those doing the exam, those numbers are not absolutely essential to get the marks, I could say. I think the examiners like it when we see it. So if you do have time, just quickly sticking down normal versus abnormal. Don't have to give a gazillion little things, but if you do know it, just quickly jot it in. The examiners like it. Right. Okay, let's back to the talk. So the first thing we're going to talk about in respiratory failure is there LV systolic abnormalities? If there are, you can get forward flow issues, of course. But I think in respiratory failure, what's also important is if you've got LV systolic function, if you've got LV systolic dysfunction, by definition, you're going to have LV diastolic dysfunction, which means that you could have a raised left ventricle end diastolic pressure. And that's important because it could give you raised left atrial pressure, okay? And if you've got raised left atrial pressure, particularly in ARDS, that can be a problem because for me, the definition of ARDS, along with all the usual Berlin guidelines or whatever, we've got, one of them is that we've got a normal left atrial pressure, right? So let's go back around. So Lewis, talk to me about how you decide that you've got a normal left atrial pressure in the critically ill with echo. Oh, you're on mute, mate. Or do you want to choose this?
Yeah, sorry. No. So normal left atrial pressure. So you look at the diastolic and work your way through the flow charts to determine whether it's a left atrial pressure. There's a couple of early things that you can look for, like a V bump and L wave in your sort of general assessment. But working your way through the diastolic dysfunction flow chart, you'd be looking for E wave less than 50 centimeters per second, the EA ratio of less than 8. That'd give you a normal left atrial pressure. Yeah,
good job. Can you get you can get E to A that's less, that's 1 to 2 though, and you still got normal left atrial pressure. So what else can you look at, which is particularly good?
Yeah, so then you're looking at the other indices of diastolic function. So you're looking at the E over E prime greater than 14. You're looking at the TRV max greater than 2.8, and the E to E ratio, E over A, as between 0.8 and 2.
Yeah, cool. All right, so just we'll pick on a few things. So I know you got probably kids or something in the
background. Sorry, I didn't mention left atrial volume.
Yeah, nice. All right, so Vishal, so we've talked there about the E to A ratio. We've talked about the E prime. We've talked about the E to E prime ratio. We've talked about tricuspid regurg, and we talked about left atrial pressure there. So just run through for me again, what would give you a normal left atrial pressure with all of those 5 measures? And then Sid, you're going to tell me what's wrong with all of those measures. So just run through those again. So what's the E to A ratio?
So E to A ratio, so it depends. So E to A ratio, if it's less than 0.8 or equal to 0.8, but E wave more than 0.5, then it's normal. But if it's less than 0.5, it's a grade 1 diastolic dysfunction.
Yeah.
And so in terms of tricuspid regurg, if it's more than 0.8, it's suggestive of raised left atrial pressure. Less than that, it's towards normal. And E to E prime around 8 to 10 is normal, but more than 14 is the cutoff, which goes into diastolic dysfunction.
Yeah.
And the last is left atrial volume index. So
Yep.
if it's enlarged, like 34 is the cutoff. Less than that is suggestive of is normal.
I remember 34 is indexed. So I think you've got to say
yes,
it.
Index.
Yeah, nice. Okay, so for me, the E to E prime, it's 8 I have as the cutoff, and 14 is the higher level. In between those is a gray zone.
Yeah.
So if I'm asking for normal left atrial pressure, you've got to say it's E to E prime less than 8.
Okay.
All right. If it's over 8, it's in the gray zone. Over 14, that's very suggestive of raised left atrial pressure. So Sid, let's talk about what are the problems with all of these, particularly in the critically ill, right? Because both Vishal and Lewis here have quoted the ASC guidelines for the thing that we looked through. And very clearly in the first sentence, I think they talk about it not being very good in the perioperative setting or the pediatric setting. I think they also probably mean in there the critically ill setting. Because, for example, let's say a left atrium can be normal in size in the critically ill, but we can have an E to E prime very much greater than 15. So we can have raised left atrial pressure in the critically ill with a normal left atrial volume. So I'll kick off with that. So that's a problem with the left atrial size. What's the problem with some of the other ones?
So if we talk about E to A ratio,
Mhm.
First, it's a load dependent
Excellent.
measurement.
Yep.
E wave can go up in cases of valvular regurgitations or the left atrial compliance and the left ventricular compliance. It gets
Yep.
altered and may not give an accurate measure. Filling pressures, the volume status, all of those sort of measures will, and the angle and the and the adequacy of your image will also affect the E to A ratios. When we talk about the A wave, it depends on the sinus rhythm. If the patient is very tachycardic or there's atrial fibrillation, which is very common in the sepsis or the ICU category of the patients.
Can you give me the TDI? Give me problems with the TDI now?
Yeah, again, it depends on the say patient's got mitral valve disease and atrial calcification will affect the
regional wall motion abnormalities.
Regional wall motion abnormalities.
Yeah.
All these measures will affect the E to E prime.
Mm.
If you talk about the TRV max, patients with again on ventilator will have an artificially elevated afterload of the right ventricle can give you a tricuspid regurgitation. Volume status again will affect it. The loading conditions will affect the tricuspid regurgitation. Patients in ARDS, hypoxia will
very
affect
nice. Very nice, because one of the things I talk about with the TR is that it's got to be when you don't have other causes of pulmonary hypertension there, right? Because we've all seen people with TR over 2.8 who've got pulmonary hypertension. We see that all the time, right? And that's where we've been talking about these diastolic guidelines. You've got to say the TR is when you don't have significant pulmonary hypertension. And in critically ill, we've got about 100 reasons why they've got a bit of pulmonary hypertension, right? Not least acidosis, hypoxia, hypocarbia with the reflex pulmonary vasoconstriction.
And same goes with the left atrial volumes in acute settings. Left atrial volume and area may not be elevated.
Absolutely, excellent. I think it's also worth talking about how difficult it is to try and get all of these values sometimes in the critically ill. You know, so these are Doppler, these are all angle dependent, and imaging is sometimes tricky in the critically ill.
Proper probe positioning and all patient's positioning, all those things.
Yeah, nice work, nice work. Okay, so we've talked about LV systolic function. So that can give you forward flow issues. That can also give you the raised left atrial pressure, which, you know, that's probably an exclusion criteria for talking about ARDS. So we want to make sure that we've got E to E primes at least less than 14, if not less than 8. We've got to make sure that we've got left atrial volumes that are, you know, closer to normal. I was going to add in about the interatrial septum pushed over to the right. In the apical four-chamber or the parasternal long axis or the subcostal view, that can indicate raised left atrial pressure. So seeing a left atrial thing wiggling around is probably important. Nice one. So now let's talk about ARDS. So when we've got all these problems that can give us pulmonary hypertension, how do we assess the RV afterload? So Ben, I've got a few sort of pointers in here to kick things on their way. So how do we talk about RV afterload?
So I talk about RV afterload in terms of the physiology and then the echo findings. I mean, from a physiological point of view, it's, you know, it's raised pressure that the RV has to contract against to try and overcome and get blood flowing through the pulmonary circulation. The way we can assess that is by looking at the RV and looking at both forward flow and backward flow from it during systole. So with regards to forward flow, using the images that you have on the screen, we can look at the pulmonary valve acceleration time. So the pulmonary valve acceleration time should only be greater than 100 milliseconds. Shorter than that indicates there's raised pulmonary vascular resistance, and that can be significantly shortened, and you can develop what's called a mid-systolic notch, as is evidenced there in that first screenshot. But there are also caveats to that. Just as a side note, if the gate is too close to the wall of the pulmonary vessel, then you can get an artificial mid-systolic notch, which may be the case there, but I see the acceleration time is short. In terms of RV afterload, other things that I think about is what the right ventricle is doing in terms of its RV wall thickness, and if there's consistently raised or persistently raised pulmonary RV afterload, then you're going to get thickening of the RV free wall, and then you can develop tricuspid regurgitation from that and go into RV failure. So causes of raised RV afterload can be pulmonary or can be based off circulation. So from a pulmonary point of view, obviously we're talking about ARDS in the case example you're talking us through, but anything that's causing reduced function of the pulmonary capillaries. So that can range from pulmonary fibrosis through to infective change, through to acidosis, hypercapnia, all those long-term things.
Yeah, nice,
And
good
then,
job. I think it's probably worth talking about, if we're talking about RV afterload, to
Mhm.
start off by talking about the TRV max is probably the best way you can estimate the systolic pulmonary artery pressures.
Yeah.
I think we can also, how do you measure diastolic pulmonary artery pressures?
well, I don't know.
Who are we up to? Lewis, have you got diastolic pulmonary artery pressure? And then Vishal, you can tell me about
Yeah.
mean pulmonary artery pressure.
So PADP you can measure from the PR and Vmax.
Excellent. And add on RAP or not?
Yeah, add on RAP for all of
Yeah,
those.
good man, good man.
measures.
Vishal, how do we do mean pulmonary artery pressure?
So it's the same from the PR jet. So early peak is the mean, the late peak is the diastolic.
Excellent. Is there any other way you know? You can just do the VTI of the TR.
Okay, yeah.
Is the other one there? And I don't
Also
think you have
from
to,
the,
sorry, say again.
And then you use the mean
I
gradient.
was gonna say from the pulmonary venous pulmonary valve acceleration time also. You can
Yeah, absolutely. I think maybe another thing it's important to mention about all the things that we've talked about is that none of these measures are actually really hard. You know, they're not validated in any major way. I think we've all got a handful of observational studies that talk about the accuracy of these things. But for example, the one I'm thinking of done by Michelle Slama's group and the lovely guy who works with, oh God, I forgot his name. Anyway, but you know, they've done, there's bigger studies that have done to sort about the accuracy of TR and the critically ill in, like, you know, 60 patients or something. So we should all say that none of these are fantastically well validated. And Ben, okay, the next thing I was going to say is about pulmonary acceleration time is actually probably the biggest masker of pulmonary vascular resistance.
Yeah.
That's probably one of the best things to mention. Of course, it talks about pulmonary hypertension, but it's pulmonary vascular resistance is what the pulmonary acceleration time does. I have 90 as the cutoff. I think probably, I'm sure there are articles out there that talk about 100 being fine. 120 is definitely normal. So there's this kind of gray zone in there as well.
Right? Yeah.
And then that flying W, that's absolutely indicative of significant pulmonary hypertension. All right. I've just had another thought. Lewis, sorry, I'm sorry to jump back, and I've just had the thought. If you're you sound like you're still probably slightly distracted, but maybe just a comment. When you were talking about LV diastolic function and looking for a normal left atrial pressure, I think it's all about, you've got to start with the simple things first. I think if you're talking about the B bump and the L wave before you've mentioned about the EA ratio, E prime, and left atrial size and the 2D thing, I think, you know, you're at the risk of, you know, examiner raising eyebrows and waiting. So start with the simple things first. I think the icing on the cake is talking about B bump and L wave, but just don't go for that first. Talk to them about the basic things first. You know, this exam is all about just doing the basic things well. Sorry to jump around.
Yeah, I guess they're just things that I often notice before I start doing the diastology.
Yeah, and absolutely, I'm not saying it's wrong. I just think in terms of the exam technique, you know, I don't know, what you just don't want to put that examiner, you know, put the examiner at ease and just start in with the simple things first. Because you know, on the marking sheet, right, they may have B bump and L wave, but it's right down at the bottom of the list. And those first things they're talking about are those, everything you mentioned, but just, you know, making it easy for the examiner, I guess, is the go.
So, yeah.
We talked all about RV systolic function. I don't even need to go through that again. Okay, shunts. How common are shunts, Vishal, in the critically ill?
So it's not uncommon. So patent foramen ovale, it's 1 in 4. So around 1 into 4 to 1 into 5 patients they have patent foramen ovale.
Yeah.
And so normally in normal life, you know, it's, you know, get undiagnosed, but when they're critically ill and ventilated, so right side pressure increases and they may open up the, you know, patent foramen ovale, and then
what's the significance of that?
So the 2-3 things. So first thing, you know, it will increase your risk of getting some kind of embolism and, you know, pulmonary embolism. And you can get hypoxia just because of right to left shunt, because of the mixing. And these are the 2 things I can think of at the moment.
It makes me think, I suddenly just sort of thought, does anyone see a lot of strokes in COVID? Obviously, we saw a lot of PEs with people with COVID. If you got patent foramen ovales that are, you know, happening in 20 to 25% of patients, you'd almost have thought that we'd get more strokes, wouldn't you?
Yeah, so embolism of any kind, that's what I was saying.
Yeah, you're completely right. I'm just sort of thinking out loud. I would have thought that we may have seen more strokes, and certainly with the amount of PEs that we did. I don't know if anyone knows of any studies that have suggested that, but
I've not come across any studies, and anecdotally, I can think of 2 cases of stroke that were very chronologically close to COVID, and we've had 400 patients through the wards in the last 3 months. So
interesting. Okay, last thing is going to be about right atrial pressure estimation. We talk about volume status here. I think right atrial pressure, I'm sure we don't need to go through this one, but talking about IVC, again, massive gray zones in there. I think what we can say for certain is the right atrial pressure is about less than 7 if you've got an 11 millimeter and collapsing IVC. It's definitely greater than 15 if you've got a plethoric, 21 millimeter plus with no respiratory variation, or maybe less than 25% respiratory variation. I add in hepatic vein assessment to try and help with that. And if you've got one like this, where you've got both systolic and diastolic pointing down, with the systole being bigger than the diastole, that's again suggestive of normal right atrial pressure of less than 7. And if you've got systolic flow reversal, that would be suggestive of greater than 15. And of course, it can be even higher than that. All right, go through this interesting case because I think this describes quite a lot of what we're doing. This is a 63-year-old gentleman who was with us at the end of last month with COVID pneumonitis and ARDS type pattern. So second admission to ICU, the first time he came just for hypoxia, settled on non-invasive, went to the ward, became increasingly short of breath, fevers, and came to us because of tachypnea, hypoxia, tachycardia, tachypnea, and hypoxia. We started managing him on NIV with just FiO2s of 0.4 with reasonable saturation, but he was certainly got an increased work of breathing. Background history of 2 stents and ischemic heart disease, hypertension, and we did diagnose a PE on a CTPA from the previous admission, so he was on heparin already. Okay, so just in the meaning of time, I might just skip through this case and we'll talk more about the stuff that comes afterwards, because basically the first echo is essentially normal. So again, just doing that systematic approach, we're going to start thinking about the LV systolic function. I used this was our first image we got about the parasternal long axis view. And you can see the way it almost looks like an apical 3 chamber. And that's because in the critically ill, obviously, as you're starting to get in those tricky to image patients, there are tips and tricks to try to image people who are tricky to image. And one of the first ones was the parasternal long axis view that I'd suggest if you can't get it in the 3rd or 4th intercostal space in that parasternal view, just keep moving down. And sometimes you're picking it up, in the 8th to 9th intercostal space. And what you see is as you go down lower and lower to try and find that parasternal long axis view, the LV sort of gets more and more and more upright. So this is an example of having a very, very low parasternal long apical window. Parasternal long window is very, very low. All right. So it's almost at the same level that you get for your apical views. But we can see that we've got a reasonable, or you've got a normal LV function. I'd even accept probably mildly impaired, but it's nothing majorly abnormal. And the walls, as already been told by Lewis there, of the anterolateral and the anteroseptal and the infralateral. Apical 4-chamber views, sometimes not the best, but we can see it sort of backs up our view that we've got normal LV function. The RV does not look dilated in this, so it doesn't look greater than 60% the size of the LV. Left atrial pressure has the appearance of maybe of being normal. I think that interatrial septum is not pushed one way or another, but obviously the views are not great. And in the subcostal view here, actually you can see that interatrial septum a bit better, being pushed over to the right, suggestive that maybe the left atrial pressure is a bit raised. Right ventricle function looks normal. LV function looks normal. So maybe this would be the type of person we'd look for some diuresis. Having said that, we've got the other ways that we can assess our heart. So we can see that we've got a mildly elevated, maybe normal cutoff for the left atrial volume, 35 mils per meter squared. It's right on the cutoff. TRV max is less than 2.8. Got the E to A ratio of 0.8 and then E to E prime of 8. So all of these pointing towards normal left atrial pressure. But this would be certainly someone I do not think we'd be giving fluids to. again, just like Lewis said, these are the guidelines I use, not validated in the critically ill. But here we can see with the normal left atrial pressure or grade 1 diastolic dysfunction, you've got 2 or 3 or 3 of the above negative. So that's the E to A less than 0.8, E prime greater than 50, or an E to A less than 2 but greater than 0.8, but having a E to E prime that's less than 14, a TRV max that's less than 2.8. Okay. When we're looking for TR, search all your views possible, particularly the apical 4-chamber, short axis are my go-to ones. You can get it from the short axis of the subcostal, and I'll show you that in a sec. Pulmonary acceleration time, 140, 116, average them out, greater than 120. Happy days, this is probably normal pulmonary vascular resistance at this stage. I don't know if a lot of you are using this. So for the difficult to image patient, another tip and trick is to use the subcostal window. As we all know it from the apical 4-chamber view, but if you rotate the probe about 90 degrees and look over to the patient's left, you can start to get short axis views. And if you can then fan back a little bit, you can get a short axis of the aortic valve. You can see the liver up at the top. And this gives you a really nice view down there for kind of a second bite at the cherry to look at things like the pulmonary acceleration time in there. And you can see you can get pretty nice views, I think, of that pulmonary acceleration time from the subcostal views. It's not so great for tricuspid regurg, but it's pretty good for looking at that RVOT, VTI. Nice to see the closing click in there. Make sure you're at the same place every time when you're doing it. And it also encourages people to do it in the same timing of the respiratory cycle. So I normally just do it at the end of expiration. Fluid status. Because we were concerned about the raised left atrial pressure here with the intra-atrial septum pushed over to the right. I think it's good to see the right atrial pressure looks like it's small, almost completely collapsing. That's going to be close to a normal right atrial pressure in there. I think with all the pictures that we've seen about a normal left atrial pressure and a normal right atrial pressure, these would be the kind of people I'd be, if we do start to see hemodynamic instability, I wouldn't be pushing a lot of fluid into these patients, even though we've got normal right ventricle function at the moment. And with a guy with ARDS, obviously the last thing we want to do is push him over. Okay, so thoughts so far. I don't think we've got any major LV dysfunction. We've got normal left atrial pressure, no major increase in the RV afterload. There's no obvious fluid overload or increased RV preload. So happy days. That's a nice sort of first state to be in with someone who's coming in with an ARDS pattern, not ventilated. So I thought from here, our plan was to carry on with NIV. If he needs intubation, we're going to intubate it. We're obviously going to try and hold off if possible. But there are no major red flags from a cardiovascular point of view that would say that we need to sort of err on a horrific side of caution because of RV dysfunction. Thought of you, Ben, you know this case because this is the guy I consulted you on, but this was where we sort of thought about steroids late on in the COVID pneumonitis. I mean, this guy was deteriorating and it was like I think it was day 14 plus with his COVID pneumonitis. And so we had elected to give him steroids later on in the piece. And maybe that's another time for another talk on that one. Okay, he falls off the perch on about day 3 or 4, worsening infiltrates bilaterally, worsening hypoxia, increased work of breathing, and he gets intubated. So, Lewis, take me through the second echo that we did, because we saw significant hemodynamic instability after intubation, as we saw with a lot of these patients. How has the echo changed?
Yeah, so straight away you can see that the RV-LV ratio has changed dramatically, with the RV being almost the same size as the LV, and the interventricular septum is essentially pushed across throughout the whole cardiac cycle. So there's pressure volume overload evidence there. So very likely a lot of the change in intrathoracic pressures, plus some hypoxic pulmonary vasoconstriction.
Very nice.
The underlying.
All right, Vishal, take me through these images.
So apical 4-chamber view, and very, very abnormal study as compared to the previous study. So biatrial enlargement, right atrial is significantly enlarged, and the intra-atrial septum is pushing towards the left, and the right ventricle is severely enlarged, and also with the interventricular septum is also deviated towards the left, and there's interventricular
Interdependence.
The motion of the septum. And in terms of the function, so there's a TAPC on the left side of the image, and which is slightly reduced, 14.6, so mild RV dysfunction. And in terms of the left side of the heart, so left ventricle is enlarged, looks like it's severely enlarged, and right ventricle function appears normal, anterolateral inferior septal valves are contracting very well, and both the tricuspid and the mitral valve appears normal in morphology and opening very well.
Nice. Sid, we had mild RV systolic function called there by Vishal. What do you think just by looking at the RV? Don't worry about the TAPC, but what do you think just by looking at it? Would you call it mild, moderate, or severe?
There are a few things that stand out in this image. One, I can't appreciate the RV free wall, but the apex seems to be made or shared by both RV and LV. And the RV certainly looks dilated and bigger than the left ventricle. The annulus probably is enlarged, but I need to measure it. I think it's a severe RV dysfunction.
Yeah, I agree. I mean, I think I'd have called it, I'll just stick in the middle. I got moderate in my head just by looking at it. But I guess I think it's right though, that it doesn't look mild to me. And I think maybe this is, and I'm not saying this is wrong, Vishal, this is again, just me sort of talking out loud. I think TAPC is not perfect. It's a pretty good measure in terms of it's easy to do. I'm not suggesting we shouldn't do it. I'm just saying that we've got to put it all together. And I think your eyeball, when you've done a lot of these things, is important to use, because I'm guessing that if we did the fractional area change on this, it would be way less than 35%, right? And the TAPC is pretty good because it's easy to do, but it's only looking at one section to try and describe a complex conical structure that's wrapped around the LV. So you've got to take it with a pinch of salt, I guess. It looks mild, the TAPC is mildly reduced, but the eyeball suggests it's significantly more than that. And that's where this would be a good indication to start, where the benefit of doing things like fractional area changes for me, and where speckle tracking sort of comes in potentially.
Oh, I completely agree, Sam. And I just thought, for the exam point, you would just describe what you can see. And,
yeah, good call, good call.
Yeah.
All right, Sid, what are we looking at here? And is it normal or abnormal?
Yeah, this is two-chamber view showing the anterior and the inferior wall. Is it a four-chamber view?
Yeah, nice.
Introseptal and the anterolateral wall with a contrast study. Contrast being given to the vein and the normal opacification of the right side of the ventricle, of the right side of the heart, with I know in how many beats the contrast is appearing on the left side is the main important point. If there's a PFO, it should appear within 3 or 4 cardiac cycles. Normally, it usually takes 9 to 10 cardiac cycles.
Try and bring it through. So it's just coming in now. So that's coming in there. Okay, so I'm looking at the red marker at the bottom now. So that would be 1, 2.
Yeah, that's coming.
3, 4. So it's definitely coming in within 4 cardiac cycles.
This is definitely patent foramen ovale, probably because of the hypoxia and the ARDS, which the patient has developed subsequently, with a bubbles of the contrast appearing onto the left side across from the right atrium.
And so, what's the significance of that for this patient?
It signifies the raised right atrial and the ventricular pressures.
Yeah. Anything else? Clinically, why is it important to know about this?
It's important because of many factors, patient-related and the ventilator-related factors. Patient-related factors, patient is hypoxic and probably hypercarbic with pulmonary hypertension, which is probably because of ARDS, ventilatory settings. If there's excessive PEEP or high ventilatory pressures, with the volume and the barotrauma can cause opening of the foramen ovale with the right to left shunt.
And the last thing I'll just be talking about is the importance of the shunt, which means that we've got deoxygenated blood going from the right side of the heart to the left side of the heart. So it's also a relevance from the hypoxia side of things.
Yeah.
So absolutely. So we've caused right heart dysfunction. We've also caused a shunt to open up with the raised right atrial pressure. And therefore, we've got to look at trying to protect the ventricle. All right, Ben, talk to me about what we're seeing here. So we've...
Yeah, so I'm looking at effectively an RV-focused apical 4-chamber view. my image quality is reasonable. I can't see the full extent of, no worries. I can't,
normally everyone bags out my pictures when I'm going through them on the Vivers.
I can't see the full extent of the
reasonable.
RV free wall, which I'd like to do, but that's fine, and maybe lower the depth. The most striking feature is that despite the size of the right ventricle and the impaired RV systolic function on the B mode image, the extent of the tricuspid regurgitation is only 2.78 for the velocity, which is
similar to the one before, though, wasn't it?
Yeah, exactly.
So it hasn't gone up that much. Then it's nothing to worry about.
It's my issue with this reading is that it likely does not represent true. It represents true TR, but the reason it's low is because the RV systolic function is low. So if you can't generate appropriate pressure, then you're going to have reduced TR.
Fantastic.
More relevant in this case is the pulmonary acceleration time, which it looks like you've gotten from a parasternal short, which is dramatically shortened. It's below 60. There's mid-systolic notching evident across at least 2 of the measures. I mean, ideally, I'd like to take that, the acceleration time, I'd like to increase or decrease the size of the scale and have multiple measures.
Yeah, good job.
But yeah.
And that's why I put these 3 pictures together. It's exactly what you've done. And I think even if, we hadn't put all these pictures together, you've said it beautifully. It's about not taking anything in isolation. That's important with an echo. If you've got RV dysfunction, you've got only marginally elevated TRV max, but that's in the setting of an RV that's just gone to hell. And I think the 2 ones I love putting together, that TR and the pulmonary acceleration time, particularly with the flying W sign, absolutely. We've got significant pulmonary hypertension that's in there. And I guess it's the trick for young players, or, there's people starting off in this as they take things in isolation. Nicely done, benches. So I guess in conclusion, and in the exam, I guess I'd be expecting the good candidate to sort of take me to this point without needing a conclusion slide, basically. If you were seeing all of that, you'd start talking about the RV, I think, being at risk or at risk of failure, or, we've got significant impairment of the right ventricle from what we've done. And therefore the standard approach, and I don't think I probably need to say to anyone in this audience about what the approach is to an RV at risk, in my opinion, because you've all heard me talk about it a gazillion times. But we've got to talk about the best PEEP for optimal compliance. And that could be a higher PEEP, it could be a lower PEEP. But I would be trying to keep that PEEP at the best level possible to try and optimize the compliance, because that's going to make the hypoxia and the hypercarbia as best as possible. I should add, I have very little evidence to support any of this at the moment. The RV afterload we can reduce with nitric and prostacyclins, either or together, and I reach for those. I think I diuresed this guy anyway, particularly because of that raised right atrial pressure. And the guy became hemodynamically unstable, and instead of starting to go to the double strength NORAD, we pulled out the milrinone for this guy. And a good few days down the track, he became desynchronous. And again, I do not know the right answer to this, but I used APRV on this patient and it worked really well. And it helped, and it means that we didn't have to dramatically sedate him and sort of fully mandatory ventilate the patient. I'm just wondering whether APRV might be a good method of weaning for these patients. But again, probably a time for another talk. So I guess in conclusion, when we're talking about echo and respiratory failure, or anyone you're worried about who's ventilated with RV failure, I think these are the headlines that you've got to be able to spit out, and particularly in the written exam. Probably won't be broad questions like this in the Viva, will be a bit more point and shoot, such as I'm about to show you in the next case. But if you're in the written exam, I always used to write down, when I first got my piece of paper for the SICM exam or for the DDU, the first thing I always did was at the top right-hand corner of my sort of scrap sheet of paper I had on the side, was I always used to write think broad. And then underneath that wrote RTFQ. And the RTFQ is obviously read the question, because you've got to answer the question. Don't start answering what you want to answer. You've got to answer what the examiner's asked you to answer. So make sure we're sort of getting along the right track and you're answering the question. And then you've got to think broad. So if these, if I'm writing a question about the use of echo and ARDS, that these are going to be the headlines. Don't do something silly like forget to talk about an RA shunt, because maybe if you talk about LV systolic function, you're going to need to write for 4 minutes, and probably the same for the RV systolic function. But for a shunt, it's super easy. It's probably worth a similar amount of marks as talking about left atrial pressure, to be honest. And it takes about 2 seconds. You just got to write a few sentences. So just don't forget the simple things like RV shunt or volume status. And you don't need to write a million things. To be honest, I think writing a couple of lines and putting the heading in is enough to get you marks. So just, don't lose simple marks for these guys. And I think that's it for that question. Any questions about that while I load up the next one, or comments? Any questions, Lewis? Are you all right? No, you're good. All right, let's go on to the last few minutes. We'll just go through a DD Viva question on fluid responsiveness. Now, I love asking these questions because I think it does separate people who know what they're talking about and what they don't. I'll put it with a massive caveat that I don't do some of these things an awful lot because I think there are so many problems with them, and that's what it's all about discussing. So that's why it's important to do this, because I think you've got to know some of the limitations. 60-year-old male. It's got 2-day history of shortness of breath, febrile, tachycardia, tachypnea, comes into with ED. Chest X-ray shows a left lower lobe pneumonia, and he is intubated. Volume control ventilation, 6 mils per kilogram tidal volume. Peeps of 8, respiratory rates of 30, plateau pressures of 28. He's hypotensive, he's put on NORAD, and the question is to you, is he fluid responsive? Can't get any TTE images, you go ahead and do a TOE. So first question is going to be for Lewis, second one for Vishal, third for Sid. Lewis, is this patient fluid responsive? So I've given you on your transesophageal image, can you tell me what view it is we're looking at and what does it show? So here it's just talking about a peak velocity, and I'll tell you it's of the LVOT. So tell me what view we've got and what does it show for this top image?
Sorry, I can't quite see it looks like it's the 120 degrees transgastric.
Yeah, good. Yes, absolutely. Yours, lower gastric. Yep.
Yep. And you're looking at the LVOT
yep.
Delta peak,
nice.
Which looks like there's probably more than 15% difference between those two peaks that have been measured.
Yeah, cool. Okay, so there's a significant difference. So what does that show you? What does that tell you?
Well, that tells me that that there's stroke volume variation, but it doesn't necessarily tell me the patient's fluid responsive because they're not ventilated more than 8 mils per kilo tidal volume.
Excellent, my man. Cool. Okay, so we'll come back to that for Vishal's thing. So he's only at 6 mils per kilogram, ideal body weight ventilation. So that's good. Okay, what about the next one? We've got the SVC. So what view are you looking at, and what does it show you? And you're on mute, champ. Do you want to, Vishal? We might phone a friend for this one because I think this is in the
bicable view, and the variation in the SVC, more than 32% variation is suggestive of fluid responsive.
Nice.
And the first one was the delta Vmax, more than 20% is a fluid responsiveness.
Yeah, we'll come back to that in a sec. Okay, and IVC at the bottom there.
Yeah, so IVC. Sorry, the SVC. Sorry, I just want to add one more point. And SVC, we are talking about the collapsibility index, not just the variation. And in the IVC, we talk about the distensibility index or the mean index. And that's more than 16%, and I think more than 18% increase. That's what I really remember.
Very nice. Okay, so what are the problems with each of these measures?
So to start with the top one, so first thing, the Doppler angle is the most important one because your Doppler angle is not correct. And before that, I want to take one step back. So you already mentioned that patient should be fully mechanical ventilated, tidal volume less than 7, and I think the plateau pressure less than 30, which is, so he's meeting all those criteria.
Now, hang on, talk to me about the tidal volume. You said the tidal volume less than 7? Just
sorry, more than 7.
yes, actually, yeah, absolutely right. It's often, and I've got actually more than 8 in my mind there, but I think, yeah, it's got to be a big tidal volume. So you need a transient increase in your, tidal volumes to do a decent assessment. Which
is not the case here, because I think it's we have said the ARDS, tidal volume.
Yeah, excellent, excellent, good man. Yeah, nice. Excellent. What else do you need to know? And so if we're going to talk about, because you remember there was a study called the Fenici study that came out a while back, where they talked about actually how many patients were having these kind of measures used on them, and it only came back to being like 2% actually met criteria for this, or actually being used to do it. So I've put all of these down here for a very, very good reason. So we know that there are problems with doing this measure if you're tachycardic. There are problems with doing this if you're tachypneic. There are problems if you're breathing spontaneously. So you have to be in full mandatory ventilation. You've got to be greater than 8 mils per kilogram tidal volumes. You cannot have tachypnea. They're all, if you've got tachypnea, it impairs the ability to make some of these measurements. So I think if you're talking about someone being fluid responsive, and I'm showing you these things, the very first thing you've got to say is, do they meet criteria so that we can even use these? And that means, as I said, avoiding tachypnea, tachycardia, plateau pressures greater than 28, tidal volumes greater than 8 mils per kilogram, fully mandatory ventilated. Those are the criteria that you've got to have to be able to do it. And they've got to be in sinus rhythm is the last one. And I very clearly didn't tell you what they are. I just said his heart rate's 110. So just make sure we're talking about those criteria being there before you can make these assessments. And then it's just like you said, the actual evidence in the evidence behind these, when they actually talk about fluid responders versus non-responders, is that it's only about 10 or 12% they talk about a difference in these things. The guys that wrote the paper said they had to do that just from a stats point of view, and they all use something, there's the gray zone in there. When they use things like 20%, that gray zone is gone. So I think you can say that the evidence would suggest it being about 10 to 15%, but to remove the gray zone, in clinical practice, you use more like 20%. Yep. You got the right number here. I think it's 36% is the magic number. I think you said 32. I don't really care, but just so you know, it's 36%, I think, in the studies. And then, for the IVC sensibility index, again, depends on what you read. And it's about 18, I think, in most studies, somewhere around 20% full.
So basically, all these measures are not for critically ill patients.
Exactly right. And because I also don't really know whether fluid responsiveness is a thing or not. I think maybe it's worth saying, I think somewhere in this, if a candidate were to say, the fluid responsiveness means that if I give you fluid, your cardiac output increases. And that's what we're trying to do. If I'm giving you fluid, I'm trying to improve your cardiac output so that we will improve perfusion to your cells wherever they are. But I think we also know that we've got pretty good evidence that if we give fluid, after about an hour, a lot of the fluid leaks out and you're back to exactly where you started. And you can do it again and again and again until they're edematous and look like a Michelin man. I sort of don't know what the exact answer is, but I do know that if we give patients lots of fluid, they can have worse outcomes. And causation versus association, I don't think we know, but so I think it's a funny old term, this fluid responsiveness, I guess is all I'm saying. Okay, sorry, who haven't done the last bit? What other assessment could you use? SID. So if we've talked about the problem with all of these things, is there something that's better for this patient that we could use that would tell us about fluid responsiveness?
Passive leg raising and looking at the aortic valve variation or aortic valve VTI variation.
Fantastic. So that is exactly what we went on to do in this patient. So this is me doing a passive leg raising maneuver. These are the values that I got. I would like you to critically appraise this maneuver. And again, you can talk about good things, talk about bad things, but this is not, it's sometimes not that easy to do. It's not, I don't think I've done this in a perfect manner. Just tell me what are the good things and what are the bad things about this passive leg raising maneuver. And is he fluid responsive at the end?
Yeah. So just to critically analyze the pulse wave Doppler studies at the bottom of the screen across the LVOT. One, the gain needs to be a bit more appropriate. It's over gained, I think, because of the fuzz which is all there around the trace.
Okay.
And second, the Doppler seems to be appropriately located with a good angle, but the screen needs to be filled, and we are seeing 4 of the images, 4 of the spectral Dopplers. I think 3 is fine, and the spectral Doppler needs to be a bit bigger. It could be aligned better because there is a spectral broadening I could see onto the subsequent image. That's what I could think of in terms of optimizing the image. And when we look at the fluid responsiveness, the LVOT VTI on the first one before the passive leg raising is 13.3, and the next one is 14. And really, if it is more than 12% from my memory,
yeah, so it's not fluid responsive. Is
it's not fluid responsive.
Yeah,
heart rate is appropriate, but tachycardic subsequently.
Yeah, nice.
And the passive leg raising, if you just look at the patient positioning, probably the legs could have gone a bit higher to 45 degrees, I think is in my mind the angle.
Yeah, it is. And one of the problems that we've got is often with these Hill-Rom beds is that you can't do that. This is the maximum actually that the beds go to, which I always, you know, when I actually started trying to use this, you actually think, and they always talk about moving the bed rather than lifting up the patient's legs. So a couple of other things just worth mentioning, and everything you've said is perfect, and all of that comes beautifully from a textbook. One of the things, if you can add in a couple of things that show that you've done this a lot, I think it's good. And one of the things I might talk about is you have this closing click, because you've got to make sure that you're imaging in the same place when they're sitting upright as when they're lying down with their legs in the air. And that's why you've got to have it with the closing clicks. So the other thing to say is that it's nice to see, we probably can say that it's in the same place in both. The next part is to talk about how difficult it is to do it, to make sure you're in the same place with the same Doppler angle. And one of the things that strikes me is that if you have a look at this image here, where that one there that I've traced versus that one there, this one here looks all over the shop. And one of the things that worries me is that potentially, if we're saying this patient's not fluid responsive, you can see that there's a massive difference between the Vmax of both of these, which makes me worried that the Doppler angle is not perfect. Okay, same with this one, right? And it's almost like you can imagine with respiratory variation, I'm almost getting as the patient breathes, my Doppler angle is changing. And that might make me think that that there's potential for underestimation of the VTI as you're doing it. The way to potentially get around that is just to keep your hand in the same position and get someone else to move the bed. But it's
also
hard.
Can I just ask a quick question? Because the patient is on ventilator, is it worth having a respiratory trace at the bottom just to see that we are measuring at the right time, like end expiration?
And just try and make sure you're doing the same time every time. Absolutely.
One more thing, Sam. So do you always club this measurement with the E measurement? So how much the change in the E or EA ratio, whether the patient actually got the
really nice, really nice. I think that was actually part of my next one. No, it isn't. Tell me about tell me what you mean about that. So it's a great comment. Yeah, and I think it'd be a really nice thing. So I know you asked me the question, but I'm going to flick it back at you.
Sure.
Describe what it is.
So basically, sometimes whenever I do it, I always, measure the E wave as well, just to make sure whether patient, got actually the fluid bolus, because sometimes, your angle is not enough and you haven't elevated the legs enough for the enough time. And if you're measuring your E velocity or EA ratio, so there's an increment or increase in the E wave, it means the patient actually got the fluid bolus. And then you will see the VTI, whether there's any change in VTI or not. And for example, if there's no increase in E wave, and it means that patient hasn't got the fluid bolus, and whether that would affect the VTI or not, that's a different thing.
Interesting. I've got it slightly different in my head, and that's why I love doing these things, because you're actually questioning whether I've got this right or not. For me, I normally have that E wave is actually more to me about telling us when we've had enough fluid, because if you've got an E to A ratio that the E is greater than 50 but less than with an EA ratio of sort of say 0.8, but then you give the fluid bolus and it goes to a 1 to 2, that tells me that because it's a fluid dependent or load dependent measurement, that E to A ratio, if you see an increase coming up, that tells you that you're starting to get increasing left atrial pressures. And that tells you that you've given enough
increase
fluid.
In the cardiac output of the stroke volume.
Exactly. Yeah. So if you're not getting an increase in your stroke volume and you're seeing that, then you've given enough fluid. Is that what you're saying?
Yes.
Yeah. Fair enough. So you're putting them together. So you look as well as the change you're also looking at the change then in the E to A together. And if you've got no change in the stroke volume, you're getting a change in the E to A ratio, you definitely need to stop giving fluid.
It means you need to stop.
Yeah, nice. And that kind of makes more sense to me, I think, than talking about this fluid responsiveness thing. Actually, I think the best part of that is talking about changes in E to A ratio, because I find some of these really hard to do, I'll be honest. And I don't do them enough. I probably don't do them enough as I should, but I do find them tricky sometimes. The last question, we're running out of time, and I do apologize, would be the final caveat to this would be on day 2, you've given 3 liters of fluid has suddenly been given to this patient overnight. You know, you said they were fluid responsive, and the classic thing happens then is you then go home after you've done that, pat yourself on the back that you've done a good job, and then everyone just carries on giving fluids because they say they're fluid responsive, and you come back the next day and they look like a Michelin man. But if you've been given 3 liters of fluid, you've got ongoing hemodynamic instability, the NORAD's now on double strength, lactate's climbing up, and you get this kind of picture of RV failure. Let's say that then the trainee would say to you, but the patient's still fluid responsive, because I went and did that maneuver that you taught me, and here I can see that I've got significant variation in the Vmax of their VTI of their aortic valve. So I've kept on giving fluids, but they're deteriorating. So Sid, my question to you is, why do we have, so in the setting of this, where we've got RV dysfunction, we've got septal flattening, we've got a big RV, why are we seeing this maneuver here? And is he fluid responsive, this patient still?
It's because of the interventricular dependence. Pericardium is common and the septum is shifted to the left. Every time you give fluid, RV dilates and reducing the cardiac output on the left side.
So one of the big problems with this measurement is with RV dysfunction, you can get false positives, swings in the blood coming out of the left ventricle. Absolutely. So what measurement could you use to see if this patient is fluid responsive?
SVC distensibility probably will be a better one.
Yeah, well done. It's SVC distensibility. That's fantastic. And that, my man, is that. Thanks very much, guys. I think it's probably the end of the session. I'll see you guys later, okay?
Thanks, Sam.
And are there any final comments or questions?
I've got a comment, just that sure. I always refer to it as preload responsiveness so that nobody thinks that it's a blank slate to give fluid.
Yeah, that is absolutely fair enough. I agree. That's a nice way of talking about. I better go. I've got someone just about to visit us. I'll see you later, guys. Thanks very much for joining.
Thank you, Sam.
Cheers.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.